It's going to be a 20 minute or so session. And we are thrilled to have Kim Barrus, a former guest at Bright Spots in Healthcare, who is AVP of Quality and Accreditation at Select Health. And she's going to share with you how her team is transforming the healthcare experience, starting with access, quality, and innovation. And she's got two really cool examples that I'm three really cool examples that we've prepared and worked on, and super excited to hear it now as it's all coalesced into a presentation. And again, everyone listening, feel free to ask questions through that Q&A module. Kim, thanks for being here, and take it away.
Perfect. Thank you so much for having me. Excited to be back. As you mentioned, Kim Barrus from Select Health. We are a part of the Intermountain Health system. And just a quick little background for who we are. We are currently in 4 different states: Utah, Idaho, Colorado, and Nevada. Our total membership is just over 1.1 million. And we do support all product lines, so Medicare, Medicaid, exchange, and commercial. So that's a little bit about who we are. And I am excited to go through these 3 case studies to share. We're going to start with an example of how we're trying to meet the community where they are with some hybrid clinics. I'm also going to share a little bit about our quality provider programs. And then the third will be an experience we're having with remote monitoring related to hypertension. So the first we have here is a photograph of what we're calling a hybrid clinic in Wells, Nevada. And I want to give a little bit of a background on why Nevada, why this example, and why hybrid clinics. So a little bit about Nevada. We have 86.9% of the state is considered rural or frontier counties. 69.7% of the population is in a federally designated health professional shortage. And they are 48th in the nation for primary care provider access. So this helps to paint the picture of why we might need to be a little bit innovative in how we're trying to provide care to the members that we support, and that we're probably going to have some challenges. So with it being a healthcare desert, this particular city that I'm bringing this example to you from this morning, any of our members that live in this city would have at least an hour drive for care, depending on which direction they choose to go, up to 4 hours. So not an easy place for these folks to be in their own communities and receive the care that they need. And you can imagine with a city this small and this rural, it's really difficult to recruit providers to want to come and live in this space and support this community on a full time. So with those challenges in mind, we are really excited. Like this was so fun, you guys. This is really getting into the communities that you serve and trying to find ways to collaborate differently, not just within our own organization, with Intermountain and Select Health as the delivery system and payer, but also with the community. This is a collaboration with the City of Wells. The City of Wells provided the facility and the utilities. So that building that you saw on that first slide, that is actually the clinic that was provided by the City of Wells. Intermountain supplies the providers that are going to support the care. And then, of course, we're going to cover these services for our members so that they can receive the care that they need right in their community. The difficulty with all of this is getting all of these pieces in line, getting them all coordinating, getting all of the agreements in place, getting the system set up. But once we were able to come through and get all of those pieces put together, this incredible clinic provides multiple types of care for this community. It's not even just about primary care. This clinic can support primary care needs, behavioral health needs, urgent care, select specialty through in-clinic and virtual. They are able to provide some lab and testing right there on site. So again, members aren't having to drive for the hour to 4 hours for labs and testing. And of course, then we're improving the member experience when we're able to offer something like this. And what happens in this clinic, we've got a brick and mortar building. On a daily, as the clinic is open for hours for visits, it's staffed by an EMT. So there is a physical person there who can do some sort of assessments, vitals, take the labs, those kinds of things there in the practice. And then they set up in a private patient room, they set up the virtual system so that the member then sees the provider virtually. These providers do round. I believe it's at least twice a month, if not more often, so that those patients that they need to see physically in person themselves, they can arrange those appointments as well, but do as much as they can remote so they can get as many appointments taken care of as possible. And so it's been just a really incredible experience. It's made it so that these members can stay close to home. It doesn't take a day to travel for care, get your appointment, and then travel back home. And it's really made it much less disruptive for these folks to be able to seek their care this way and take advantage of these systems. So it's been a great member experience piece for us. The providers have really enjoyed being part of an innovative solution and being able to do something a little bit different from norm. It's been a fun experience for them. And the city of Wells is, of course, very appreciative that we're willing to put this kind of a system together to help their community. The second piece, we're going to change gears just a little bit here. The second piece that I wanted to share for ways that we're trying to be innovative and doing something a little bit different to support the engagement in healthcare. And this is really more on a provider kind of a agreement or a working relationship that then's going to positively impact our members. We call this our Quality Provider Program. And really what this presentation about us today is our Quality Provider Plus program. We add the plus when we combine a couple of programs together. So we have got both a risk adjustment group and my group, which is the quality group, that are both knocking on the door at the clinic. Both of us are very interested in working with these offices so that we can make sure our members are getting the care that they need. They're having the conditions addressed that they should be having addressed. And when we're not working in partnership, we're knocking on the door at separate times. We're creating more burden for these offices when we're both asking for appointment times. We're both taking in reports to show them how their performance is doing, or perhaps, work lists. Here's some members we're really hoping that you can work with and get them into the clinic because we see they've got some gaps that we would like you to address. And so even from one organization bringing two different reports, you're kind of having to reset and reorient to a new report. It just creates more burden for the provider and their staff. And then we have a little bit different workflow and processes. So these offices that we work with, a number of them have a large number of health plans they're working with. Some of them, I think I've heard up to 27 different health plans. So if we've got multiple people from multiple departments all knocking on the door at these practices, trying to get some attention for our initiative or their initiative, that's really disruptive for the practice, for many plans to be coming at them in even more so with multiple folks from a plan coming in. And I'm not sure I've ever heard of an area that has more primary care providers than they can handle. So this only puts more stress on the system where we already may have some access needs. And so what we had done is our quality team and our provider team, decided we want to do something different. We want to really try to reduce some of this burden on our providers, and we want to work together. See if we can put our program together and simplify. Let us deal with the complexity back home. Let us put something forward for the provider that's easier for them to work. It's more complete. We're requesting less of their time. And we can worry about how many departments we have on our side, right? They shouldn't need to know how many teams that we have. We should just be able to get them the information they need to help fill gaps in data. So you can see the second piece I have on this slide is one of the challenges that we're trying to solve is in data. So I've got listed here gaps in data. And what I mean by that is all of the folks who are in a patient's care story. So I'm thinking providers, facilities, health plans, all of us have a view of that member or patient. All of us have a data set, a record, but they're not all the same, right? Each of us have some blind spots or some gaps in that data. And so that's one of the other things that we wanted to try to solve here or improve is making a more complete picture of that patient for both our participating providers and for our health plan. And the trickle down hope for that is we have a better understanding of that member and their needs. Provider has a better understanding of the patient and that needs. And hopefully that also reduces the burden on the member or the member abrasion. If someone's got a piece of the story for that member that shows us that a gap is closed, we prevent another outreach to that member asking them to take care of a service or a care gap that's already completed. Another challenge that we have with our multiple teams that we identified as we worked to try to put our programs together is timeliness. The frequency of update or refresh to each of our reports provided to these offices was not the same. And that makes it a little tricky for the offices too, as they're trying to reconcile. So within our program, some of the first things as we come together and we're on board, we want to take on this work, which is not easy. It's complicated. So we prioritized 4 pieces first, 4 pieces that we wanted to make sure that we could come together on to make sure this is going to work and we're going to be able to move forward. Alignment on attribution. Sad to say that we had a few differences in our attribution from the same plan. Different teams had made a couple of different tweaks. And so that was first negotiation between our 2 groups, is coming together on an attribution model that we can use just one for both programs and still meet both of our programs' needs. And by attribution, this is what we're calling making that provider-patient assignment. How are we going to decide what provider's report we're going to put this member on and say, please get them in and address, which sometimes can get tricky because members don't always just see one provider. It's not just simply look to see who they're going to, because sometimes they have multiple primary care visits. So coming up with the agreement on the algorithm of this is what we all feel really comfortable with. We kind of call it voting with their feet, right? So we can make sure that we're doing our best to align the information we're sharing with providers, which then we're hoping leads to outreach with the person that member would perceive as their primary care. So the next piece is collaboration on measures. So I'd mentioned earlier, I'm quality side of the house. And so we use the HEDIS data set, the healthcare effectiveness data and information set. It's a standardized set of measures. Health plans are all required to report. We either have a partner to help us with that, or we have certified solutions in-house, depends on the plan. And this tool will run measurement. And when I say standardized measurement, that means there is really specific criteria for how these measures are run and the definition of these measures. So we know we're comparing apples to apples across plans. We're all running these measures the same way. Well, that works all the same in quality shops, but that's not necessarily how risk adjustment teams might run the metrics or measures that they are wanting to address. And sometimes we've got overlap in condition. So we'll say diabetes, right? A risk adjustment team is going to be really concerned and hopeful that all of our members with a diabetic condition are being addressed. We want to make sure those members are getting the care that they need on a timely basis. Quality side's going to be the same, right? We want to make sure that members getting in, they're getting their testing completed. We're monitoring how they're doing in their condition. We're intervening when needed. But the way that we might set up the identification of, yep, that's my diabetic, that's who I need to put on this outreach list for diabetes, might not be the same. And so that's what I mean on collaboration of measure here, is making sure that we're also coming together on the definition of these measures, who falls into the denominator, so to speak, or numerator for these measures, so that we are not surfacing a member as a diabetic on one report and then they're missing from the other. That's something our offices catch up on, right? And so prior to us combining programs, that's something that we would hear a lot. How come I've got this member on this list, but I don't have it on this list? So that's something we wanted to tackle early head on. The next piece is something I'd referenced on the last slide, right? These multiple meetings for these poor offices with us each trying to get some attention. And so working together to streamline calendars and align with what works with the providers' offices, working with what we're trying to present, because we didn't want to combine those meetings and extend the time. Right? That's not making an improvement as far as the stress on the clinic. And so we really worked to streamline and simplify what we needed to review and go through in our discussions with clinics so that we can condense these meetings. It's a little bit of a trick for both of us because we felt like we have so much content we want to share, and we've been feeling the time that each of us was using. And we had agreed we were going to get it down to just, the one set of meeting time. So if we're meeting for an hour, we're just doing an hour. We don't want to stretch it beyond that. And so we had to get a lot more succinct ourselves in what we were putting forth to present. And on the quality side, part of what we're doing with these offices from the quality team for us, for our program, we're not just delivering gaps in care and here's your performance. We are also supporting this program with 2 different resources from our team, one more in operations, project management kind of a role, and the other is a clinician. And the reason we have this pairing is so that we're kind of helping to take care of this clinic. We say no clinic left behind. We're trying to make sure that we're kind of filling gaps in with resource for the clinic so that we can work through continuous improvement, best practice. We've got some tools that we offer to help these offices through setting up transition of care or social determinant screening, those kinds of things. Some of those things take time. And so that's where some of the trickiness comes in for how we collaborate on these, condensing the meeting times, making sure that we're not shorting either of our programs or the services that we're offering to these clinics when we're combining the time. So that was a little bit of work for us to kind of navigate through. And then combining our reporting. So each of us has our own analytic support. And if you've worked with more analysts, there's a style to creating reports. Plus our programs kind of have a style and a desire for how we want things put together, what we want to show or be prioritized. And so combining the reports was another tricky negotiation between our groups. I had occasion to do an overhaul for our quality programs at our health plan probably 15 years ago. And what I initially did is I went out to offices and I said, help me understand how we as a health plan set something up so we're collaborative, we're working together, we can give you what we need and get the heck out of the way. And the number one thing I heard across the board from every single practice was give me one place to go, right? I mentioned earlier, these clinics have multiple plans that they're working with, and it's really difficult when each plan has multiple places they want to direct you to gather information, alerts, reporting. And so that's something that we had always done in our quality space is put all of our quality reports in one link. Here's the one place you need to go. And so we worked with the risk adjustment team to combine and put all of their reports in one place too. So they still have just the one clinic or the one place to go to get reporting. They can get to their quality gaps in care. We provide case management reporting in there. We want the clinics to be able to coordinate and collaborate with our care management team if we have one of their patients in our care management program. So right in that same space, the providers can see, here's the program they're enrolled under, here's the nurse that they're working with, the name, the phone number, if you'd like to collaborate and get in touch with. We provide the daily facility census and emergency department report. So it's a pretty rich data set just with the quality pieces, and then adding the risk adjustment pieces in made it a pretty powerful one-stop shop for these offices to gather everything they need to be able to work. To us, two programs. What we're hoping to present to them now is just one program, easier to work through. So challenges as we work through these, I'm sure you can imagine the attribution logic, as I mentioned. We get really passionate about some of our reporting, some of our attribution models. And so that took some time to get through. The measure definitions, as I mentioned, was another place that was a little bit tricky. What we tripped on a little bit between the two departments is kind of the expansion or the honing in on who those populations should be for those metrics. But we were able to come to negotiation on both of those two things. And then, as I'd hinted to, the analyst alignment, trying to get these two different styles working together so that we can present what looks like a united front and a single report, that it's style-wise, flow-wise, layer-wise, right? How I flip through the data and drill through, so that those were all aligned. So it didn't feel to the office like they were having to learn two different reports just in a link. We wanted them to feel like it was just one report. So those are some of our competing priorities we had to work through with quite a bit of effort. And I am happy to report that we are live with our QPP Plus program, this combined program, in all 4 of the states that we work in. And some of the benefits I've put up here on the slide for you that we're experiencing, the provider engagement has improved with the reduction in meeting, the streamline of the reports, the simplification of working across these two teams now, just feeling like one, less time, easier place to go to get all the data that I need. This has actually improved the engagement because it feels like we're asking for less on their side. So it's easier for them to participate. The other really nice thing, I didn't put a bullet on the slide and I probably should have, is the provider experience. I would say we hear often from the providers, both the clinic staff and from the providers, how much they appreciate. I told you we were resource heavy with the nurse and the ops person. We regularly hear how appreciative they are that we're willing as a plan to provide so much support and resource. Some of our groups are really small, right? I'd mentioned we're part of the Intermountain system, but we're not a closed system. We have our Intermountain owned and operated clinics, employed physicians, and we have, I think, more of our contracted independent providers than we do if we were doing count of noses. We've got more independent providers participating in our networks than we do our Intermountain employed. And sometimes we've got a very sophisticated, multi-site, very large practice group that has, from kit to caboodle of all of the different types of resources, from analytics and quality, and we've got liaisons, to an office that's very small and one spouse is the front desk and one spouse is the provider. So when we have this kind of a team set up to resource to support these practices, we can kind of fill in the blanks and help where needed, and we can pull back when we're not. And so that helps us to be able to have the manpower to provide that extra higher level of support across multiple practices, because in some we're highly engaged, spending a lot of time, and in some it's more of a touch point and making sure they have access to the data because they're killing it and they just needed the data. They needed less of our team. So that's been really great on the provider side. Hi, Eric.
How you doing? I have a couple of quick questions. And incidentally, this goes against complete common sense when you do these things, but I'm going to do it anyway because this has been such a unbelievable presentation. So congratulations and thank you.
Oh, thank you.
For everyone listening, if you want to ask, obviously you have the Q&A module there, which I've been promoting. But if you want to ask a question right now live, we didn't plan for this, so I'm sure the production team is not happy with me. There's also a raise your hand button at the end. If you have a question that's related to these 2 case studies that were just presented, specific to these 2 case studies, and I'm going to be a tough moderator here, you could raise your hand and we'll call on you just in a moment. Becca, don't do anything just yet. But so if you want to raise your hand, one of our producers, Becca's going to choose you and we'll get some live questions. But Kim, first of all, regarding the provider, getting that provider feedback, have you formalized that feedback wheel in any way through an NPS survey or anything else?
Yeah, I almost don't want to answer you because I didn't put it in the slide. We do. We have a provider satisfaction survey that we run for the program a couple of times a year. And unfortunately, I did not get you rates in here. I could provide that later if you would like, but we have done that for a couple of years now. We have some response so we can have kind of thinking coded field, right? I want to do a rate performance and I want to be able to do this across the provider community. We also have some open-ended so that we can get some more direct feedback and specific comments. So we do both.
Okay. And this program has been in place for how long?
So Quality Provider Plus, we have multiple specialty. Primary care has been live since 2010. And then we have also we have a women's health quality provider program that went live in 2018, I believe it was. A behavioral health quality provider and nephrology or kidney health went live 2 years ago. And endocrinology went live this year.
Wow. Great. That's great. I didn't ask you are these slides going to be available for distribution?
Sure.
Okay.
You can share.
Great. All right. And a few people were asking me, and I didn't want to offer them up until I got permission. Okay. We have a couple of minutes still, so I'll let you keep on going. I don't know if we should start the third case study because I don't think we'll have time to finish it. But this,
okay. Kim can talk, and she knows that, so she put the most brief one at the end. I know, Eric, I'm a problem. Okay.
Great.
The last few pieces I'll just hit really quickly while we're here for the provider program. Payments and performance I have in the middle category. One of the things that we were able to do also in these programs that boosted the engagement with the provider, we've combined our payments, which actually makes the program look more attractive because they can see better what the total comp could be for participating as this combined program. We also make more frequent payments. We do a quarterly payment, then with a one-time annual reconciliation or cleanup for late claims. So there's a total of 5 distributions. So they're getting money throughout the year, not waiting for a closeout. And we've seen an improvement in our quality rates. We show them how much potential there is versus how much they've earned, and the reporting tools as well. That's really kind of helped. We were nervous at first because we thought if we share that, then we just do a per gap closure and we take away a hit a threshold, will our rates go down? It actually increased the engagement and showing what's potential, actually kind of moved that lever farther faster. So that ended up being a real positive for us. And then the operations, we'll just leave that to simplification with a single source and maximizing the 2 teams' tools that we can offer for the practices. So the last piece we had here is our remote monitoring. This is related to hypertension, clearly. So what we had done here with this program is we complete a disparity analysis annually. We've got a partner that helps us work through this. Again, you can see we're using the HEDIS data set, which is massive. There's like 80, 90 measures in it. We select our priority 30 to run through this analysis. And the partner that does this for us or helps us with this, they have 5 comparison groups that they're going to use for each of these measures. Or I like to think, these are the windows we're looking through for these measures. How does my population look in hypertension for race and ethnicity, locale, where they live, socioeconomic status, disability status, and primary language? What's really fun, if you like to geek out on data, is to go through this disparity analysis and see how different it is depending on the measure, right? I think when you first start trying to work on disparity or inequities within healthcare and what we're delivering, we have some biases and we have some assumptions, I think, that we take of where these issues might be. It's been really fun to go through this report and see, we really need to approach these measures differently, because each of them have a different kind of disparity. It's not all the same for each of those measures. So when we look at hypertension, and you can see this is not a commercial, but I wanted to give credit. Decision Point is the partner that helps us with this. And you can see I've pulled up our controlling blood pressure measure, which is how we monitor our hypertensive patients. And if you look at the legend at the top, that helps to kind of make that grid easier. A blue dot indicates we've got a 3 percentage point disparity. the box is a 10% and the star is a 20%. So you can see about mid of that grid there are locale, rural versus non-rural, especially for our commercial, is where our biggest challenges are when it comes to hypertension. And so we decided
And again, is this for all LOBs?
Yeah. So these codes here, and I'm sorry, I didn't include this in my legend. COM is going to be commercial. MCD is our Medicaid and MCR is our Medicare.
Copy.
Perfect. So this is what helped drive us to, this is where we want to focus and what we want to do. And as we worked with our HEDIS team and population health, and we're trying to figure out what could we do out in this area. And again, we took advantage of our integrated system here to find a clinical partner to help us pilot and test something out. And we decided we were going to try giving members in rural areas blood pressure cuffs and education on monitoring and tracking their blood pressures at home and making sure that they're sharing those with their provider. We sent out communications offering to the members, let us know, we'll ship it right to your house. It's free to you. These are some of the roadblocks and issues we had right at the jump. Perception of the insurance company was a little bit tricky. We're not as trusted by all members as the providers are. So we had a little bit slow uptake. Shipping and logistics was a challenge for a minute. And then complexity of the process working across different divisions. Collaboration is key. I have noted this is just a hot list. We won't read the list because we've got like 60 seconds, but this is a roster of all of the groups that we had to work through to solve the problems on the prior slide. And for that slow uptake, we started making some phone outreach to members so that we could better explain what was happening. And our clinic partner in the rural area also started messaging and talking with our members to help us socialize the program and get it rolling. And so this is our outcome data from our pilot from last year. So you can see we did see some improvement from the pilot that we ran. And this year we had a group that heard about our first pilot that reached out to us offering the remote monitoring so that we're leveling up in the project for this year where we're not just sending the cuffs and having them track and go to the provider. We actually have somebody monitoring them ongoing and sharing the information with the provider. So I'm excited to be able to report back to you, Eric, after this year on what kind of improvements. We're hoping these numbers have a big jump when we've got this addition of the remote monitoring.
This is like 3 different episodes I want to do with you now, Kim. Like my whole, I was already thinking, oh my gosh, we got to have you come on with it for a deep dive into any one of these 3. So thanks so much.